So here is one baby, actually, that I did an embolization on with a hepatic hemangioma. I'm sorry the X-ray is somewhat white, but the heart is very large. The ultrasound here shows numerous vessels with no parenchyma suggesting there's a tumor like a hemangioma. It's just a lot of vessels with an enlarged hepatic artery, the shunt seen on Doppler. And here is the angiogram, an aortogram done. This actually aortogram, I'm sorry I haven't got it on a loop, but this aortogram was done from the brachial artery with a high flow Renegade microcatheter. And you can easily, in this baby, putting in 4 cc's a second, you'll get this type of picture. And you can see the rapid shunting back on into the right atrium through enlarged hepatic veins. And when you're presented with this, it actually is somewhat unnerving when you see it. And what you can see is in this baby, and this was a CT scan that came with the baby to our department, and it can be mistaken for a tumor because this was reported as being a focal tumor in the liver. Well, it's not. This is just a conglomeration of blood vessels. And if you try and re-window the CT, you can really see that there are separate vessels, but it's still very hard to tell this. And you wouldn't put these babies through diagnostic angiography unless you were prepared to do the embolization at the same sitting. And here is the angiogram on this baby, similar to the last child, the last neonate. This is a neonate. Actually, I'll tell you, both these babies with hepatic AVMs weighed 2.7 and 2.8 kilograms. They were slightly premature. So there's rapid shunting. And so the decision is really, well, we've got to do something about this. So we decided on both these babies, actually, and I don't know why, but they appeared within 6 weeks of each other for us to embolize. These are extremely, extremely rare conditions, and most pediatric interventional radiologists may deal with one, perhaps, in their work. But what we decided to do was to try and get the glue actually into some more of the central circulation, so into the equivalent of the nidus. You can cast. You must always do these things coaxially. There's no reason to not do that. And we actually tend to use the dexterous sandwich technique for much of our glue deposition. And here is an example of some of the glue going in, staying. You'll see a little bit, but this is still within the intrahepatic circulation. There's none going up into the right atrium. This glue is actually, when you say percentage, I sometimes get a bit confused. So it's 1 part glue, 1 part lipiodol. And the total volume in this, 0.2 cc's. And we might do several little aliquot injections depending on the feeding supply. And in fact, this is the glue cast that you can see here in the liver. And both these infants were weaned off their inotropic support within 24 hours. And really, these are two of a few survivors that I know about. Here, in the second case, what I'd like also to show you is that there was a significant supply from the SMA as well. And so we decided to try and the SMA supply. And unfortunately, in the second baby where this happened, there was a small area of gut infarction, and the baby developed a perforation and required a laparotomy. But the baby came out of cardiac failure, has done incredibly well. I've seen both these babies actually in the last 6 weeks in our vascular clinic, and they are now really doing well. They're about 2.5 years of age. They've never looked back. And here you can see the chest X-ray before embolization in this hepatic AVM, and the chest X-ray showing reduction and normal-sized heart after the embolization. And the anaesthetists, these are obviously done under general anesthesia, and the anaesthetist during both these cases said, these hearts are getting better. The babies hemodynamically are much more stable. I'm turning down the inotropes during the case, so you can get that rapid response. And that goes for infantile hepatic hemangiomas as well as AVMs. So very, very briefly, I just wanted to show you some other vascular anomalies in the liver. And the first one is a congenital arterioportal fistula. A boy actually who was asthmatic, and this was an incidental finding. He didn't have any GI bleeding, and it was discovered when he presented with an acute asthma attack. And the physician was listening with his stethoscope, and the stethoscope went down the chest, down over to the liver, and they heard this noise, this bruit over the liver, and an ultrasound was done showing this fistula and confirmed on CT, and we decided, as we would for most fistulas, to treat when we discover them. And here you can see is the arterioportogram of this boy before the embolization was done, and the catheter is coming up from the femoral artery into the SMA, and you can see here is the here actually is the incomplete contrast column going into the liver, because there's reversal of flow, sorry, the late phase of the arterioportogram, and what you see is that there is reversal of flow in this portal vein. And what we actually did was, up through the hepatic artery, we actually put an Amplatzer plug into this. In fact, it was an old PDA occlusion device, it wasn't one of the plugs. And this actually occluded the fistula, and actually on a follow-up SMA arterioportogram, you can see beforehand there is no portal vein. There actually is a subsegmental branch filling here, but actually following embolization of the fistula, on the delayed image from the SMA arterioportogram, you've actually got normal inflow through the portal vein into the liver, so you've restored normal directional flow, and he's done well since. What I would say, however, is in these fistulae, the portal vein, because there's been a fistulae and it's congenital, the portal vein has adapted to the arterial inflow. The wall of the vein will have thickened. The drive to maintain flow in that portal vein has come over many years from the inflow from the artery. So if you actually close the artery, you suddenly shut off the arterialization, it may result in thrombosis of the portal vein. So these children need anticoagulation, which is a difficult thing because sometimes they have GI bleeds and we don't want to put them on anticoagulation. But if we want to preserve the portal vein initially, certainly we would suggest putting them on anticoagulation if we're going to do an embolization for a congenital portal fistula. So here's one more fistula, which is much more complex. It's not a single channel. There are hundreds of fistulae in this boy's liver. And this was his initial angiogram, done actually at an outside hospital on the opposite coast of Canada to Toronto. And they thought that his malformation was in this somewhat dysplastic looking vascular arrangement here of the hepatic artery. But actually, and he had one single coil put in this other center, but when you carefully look, when he came to us, and you carefully look actually at the arterial injection, you can see all these tram lines from the periphery, and these were occurring predominantly in the right side of the liver, but also in this dysplastic area here in the left liver, and this is refilling of the peripheral portal veins from multiple arteriovenous fistulae in the liver, and this is the reversal of flow in the portal vein following his hepatic artery injection. Well, the story didn't end there, because I think what I would have liked to have done was to try and get some agent out to the periphery of these, but regrettably he had some proximal coil embolization, and so all this did was actually promote arterial collateralization around the porta hepatis in an attempt to arterially revascularize his own liver. And so we've been, over several years, going back in and trying to top up with some glue embolizations, and we actually were doing that because he was having recurrent GI bleeds and frequent blood transfusions, and so we've actually kept things in abeyance for a few years with him, but actually it takes a lot of work, and he's actually doing relatively well, but ultimately he will require a liver transplant. If any of you ask me, does he have cirrhosis causing these fistulae in his liver? I cannot answer that because we've never got any tissue from his liver. I have suggested to our liver specialists maybe we should do a liver biopsy as well, but they say no, we don't need to. His synthetic liver function is good. He's purely got a mechanical problem from his arterioportal shunts, and if we control these,